Welcome, everyone. Thank you so much for joining our Debbie's Dream Foundation webinar series. Today's webinar features Dr. Samuel Klempner, who will give a presentation on ASCO 2023 updates. I'm Brittany Starks, Communications Director for Debbie's Dream Foundation, and I will be moderating today's webinar. Thank you to our generous sponsors for making today's program possible. Title sponsor Amgen, Astellas, Daiichi Sankyo, and Merck. Platinum sponsors Taiho Oncology. Gold sponsor Arcus Biosciences, and silver sponsors Bristol Myers Squibb and Lilly Oncology. First, I will give some information about stomach cancer and Debbie's Dream Foundation, and then we'll hear a presentation on ASCO 2023 updates with Dr. Sam Klempner. A Q&A session will follow the presentation. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is the second leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate between 20 and 30%, depending on the country. Many patients are asymptomatic during early stages of stomach cancer, leading to late diagnosis. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many recurrences. Unfortunately, Debbie passed away on December 23, 2017 at the age of 50 after a 9.5-year battle with cancer. As an organization, DDF continues her important work and legacy. In a few short years, DDF has achieved many great milestones. We have 32 chapters across the US, including Canada and Germany. Our PrEP program helps patients and families and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided $1.45 million in research grants to date. Patient advocates come together each year at our annual Stomach Cancer Capitol Hill Advocacy Day to secure funding from the Department of Defense's peer-reviewed cancer research program. This program allocates funds for stomach cancer research. Earlier this year in March, we traveled to Washington, D.C. with more than 130 advocates and held 180 meetings with lawmakers to inform them that we need more funding for this deadly disease. We are proud to say that this year was our largest turnout yet. We hope you'll join us next year as we let Congress know that we need a cure. So featured here is where you will type in your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. And we will now begin the presentation on ASCO 2023 updates with Dr. Samuel Klempner. A little bit about Dr. Klempner is that he's a gastrointestinal medical oncologist at Mass General Hospital and an assistant professor at Harvard Medical School in Boston, Massachusetts. He completed his internal medicine training at Birmingham Women's Hospital, Harvard Medical School, and a combined hematology oncology fellowship at Beth Israel Deaconess Medical Center at Harvard Medical School. His clinical research focus is gastroesophageal cancers and novel therapies. He works in a multidisciplinary team to optimize and individualize treatment using molecular characterization across all stomach and esophageal cancer stages. Dr. Klempner conducts clinical trials and translational research with new targeted agents and immune therapies. He is active in the stomach cancer community, I'm going to echo that. He's extremely active in the stomach cancer community, including local outreach, education, and advocacy. Dr. Klempner, thank you so much for joining us today. I'd now like to turn the presentation over to you.
Awesome. Yeah, thanks for having me. It's fun lunchtime discussion, and definitely I found the webinars very helpful as a resource to recommend to patients. So the Living Library is a great thing. I put a ton of stuff in here, so I may breeze through some of it, but that's why these slides will be available to you on the webinar. Let me see if I can click through. All right, my disclosures. All right, so I'm going to talk about non-metastatic. So this is like stage 1 through 3, where really it's all about testing. That's what the new data is going to point us towards. And then we'll talk about advanced disease, which unfortunately is the majority of our patients, where it's really all about targets. So I put in a couple slides that are probably even things you already know, because I find the people involved in DDF and other advocacy groups have really done a great job educating themselves. But basically neoadjuvant therapy, so stuff we do before surgery, has the goal of killing off tumor cells that are there. So we call it debulking the tumor, making it smaller. But really the main point of it is to kill the stuff we can't see. So those are like single cells that may have already spread to other areas in the body, whether it's a lymph node or the liver or lung, etc. So we have scans that tell us as much as we can see, but there's a bunch of stuff we can't see, and really those are the things that become the problems in the long term. So what we want to do is kill, obviously, the stuff we can see, but we really want to kill the stuff we can't see, because those are things that can't see it, so we can't target it for removal during surgery. There's really a couple major approaches that are the standard. So basically, you go from left to right. Everybody starts when they get diagnosed. And then either people have a surgery up front, which is not very common in the United States, but is more common in Japan and Korea, and get chemo or something after surgery. That's called adjuvant therapy. And then for stomach cancer, the most common approach in the US is chemotherapy, whether it's FLOT or other, followed by surgery, and then more chemotherapy, and that's called perioperative therapy. So this is what the standard is. This is sort of our benchmark data that we're trying to make improvements on. So FLOT is an intensive chemotherapy. It's 3 drugs of chemo, and I put them over there on the right. And then you do that for 4 doses, so it's 2 months. Then you get another scan. If everything looks good, you get surgery. And then once you're recovered from surgery, we try to give you some more chemo on the back end. And even with all that treatment, you can see that the 5-year survival rate is still less than 50%. So we're doing the best we can, but it's not nearly good enough. And certainly the quality of surgery makes a difference. So having your operation by someone who knows what they're doing. But this is where we're at, and this is really not very satisfying for us, and definitely not satisfying for patients. Even go through this intensive therapy and our cure rates are still less than 50%. This is way less than breast cancer or prostate cancer, or colon cancer. So we're trying to tease apart those groups of patients, because right now we're lumping everyone together and we treat them all the same, but really everybody's different. And one group that has dropped out as clearly different is microsatellite high or mismatch repair deficient tumors. So first, it's very clear that these patients have a better survival. They do better no matter what you do. But it's important to observe that even when we give these patients the standard chemotherapy, they don't really get the benefit from chemo. They do just as well as if you had operated on them right away. So rather than exposing to all this chemo, which let's be honest, it kind of sucks, you can avoid chemotherapy potentially in this really well-defined group. And so it's about 10 to 20% of patients, so maybe 1 to 10 to 1 in 5 people. So it's not really that rare. But if you don't get tested, then you'll never know. So testing is not actually standard yet, although I think myself and many others feel that it should be. So when you get diagnosed with a stage 2 or a stage 3 and someone says, we're going to give you FLOT, I would say you should say, what's my MSI or what's my MMR status? Because maybe those patients don't need chemo at all. In order to sort of prove that, they did this trial, and this is one of the newer updates. They gave MSI high patients, so that 10 to 20% of patients, they gave them immunotherapy. So no chemo here, immunotherapy before surgery, and then immunotherapy after surgery. And you see that almost 60% of people had their tumor completely eradicated by the immune therapy before surgery. If you compare that to what we see with chemotherapy, which is about 15%, it's a huge improvement. So when we find the right patient by testing, and then we have therapies that we know work, things go pretty well. And over on the bottom right are these survival curves. So you're looking at the proportion of people who are alive over time. And so if you look on the right side, you'll see basically nobody has died. Everybody is alive at the follow-up time. So this is, again, suggesting this is a very promising data. This is from ASCO GI. So I combined ASCO GI and ASCO to give you guys all the data kind of all at once. And this is a trial called the Infinity trial. It's a Italian trial where they basically made it very simple. They gave people 3 months of immune therapy before surgery. So these are also the MSI high patients, that same 10 to 20% of patients. And then they took them to surgery, and then they just watched. So there was nothing after surgery. And what they saw was, here are the people, first of all, very straightforward. This is typical stomach and GE junction patients. And what they saw was that on the left side of the slide here, you're looking at the percentage decrease or pathologic tumor regression. We call this a waterfall plot. And you see that if it goes down to minus 100, that means 100% gone or complete remission. And you see that there's a large portion of patients who had a complete pathologic response. It's 60% of the people here. So very similar to the trial that I just showed you. Really, the point of this is that these therapies are relatively well tolerated. You know, immune therapy still can have some side effects. Grade 3 tend to be things that really impact your life. And so 6% is considered relatively low, but that's still 6%. And really, what does it mean for you? It's that you got to get tested. Like microsatellite high is just a different group of stomach cancer and GE junction cancer. They do better. They have different treatment approaches available to them, whether it's surgery alone or immunotherapy, which activity is quite good. And we, at my institution and at many other big institutions, are really moving towards immune therapy prior to surgery and potentially after surgery. So this is really a change in the management, but it's for the slice of the pie that's 10 or 20%. So what about everybody else? You know, most of our patients, they have stage 2, they come in, we test them, and the MSI is negative. So they're MSS or microsatellite stable. It's tempting to think about adding immunotherapy to those patients, and I'll jump to the conclusion that we just don't have enough data to really support that yet. And so I'm going to walk you through the updates that are sort of building where hopefully that might be the reality for some patients. So this is a trial from ASCO just a month ago, and basically they were asking a question, and some of these slides are a little technical, but I'm just going to kind of speak to them at a higher level. They were basically asking a simple question. So like I said, in Japan and Korea and Taiwan and much of China, they commonly do a surgery up front when people are diagnosed, and then they give chemotherapy on the back end. That's called adjuvant therapy. And so they took people who had stomach cancers that were completely removed, and they gave them standard chemotherapy after surgery, and then half the patients got standard chemotherapy plus immunotherapy. In this case, it was nivolumab or Opdivo. And then they wanted to see, does that reduce the risk of recurrence? The idea is that adding the immunotherapy might bring in some additional benefit. These are the patients that went on trial. Again, I'm not going to go through these slides in detail, but just to tell you that this is pretty typical population in Asian trials. It's almost all gastric cancers. almost no GE junction cancers. This is not really what we want to see on our curve. So when you have two curves that basically have no separation between them, that basically is telling you, sorry, it's basically telling you that the results are identical between the two groups. And so in this group, the dark line is the nivolumab, and you see that there's no difference. There's not a greater not a greater percent of people alive with nivo than if they didn't get the nivo. So this was a negative study. So you can see that there's about 65, 68% of people who are alive at 3 years with chemo or chemo plus immunotherapy. So this was not what the investigators were hoping to see, but that's why we do trials. This is a very common question that I'm sure many of you or your loved ones have faced. And so let's say you give someone FLOT. They're stage 2 cancer, stage 3 cancer, you give them FLOT, then they go and they have the surgery, and you're looking over the pathology report, or you're sitting with your oncologist and it says like no response, or there's still a bunch of lymph nodes on the pathology specimen. So basically there's still a bunch of cancer left over after FLOT. And then your oncologist is telling you, we're going to give you more FLOT. And you're like, well, why are you going to give me more FLOT when I just got a whole bunch of it and it looks like there's no response in my tumor? And we would say, well, that's what the trial did, so that's what we're going to do. And this was a very good question, which was, in those patients who don't have a great response to FLOT or other chemotherapy, what if we gave them immunotherapy on the back end after surgery instead of chemotherapy? And this was the study that they did. They took people and they said, okay, half of you are going to get what you would regularly get. You get your chemo, and the other half are going to get immunotherapy with no chemo after surgery. So everybody got chemo first, everybody got surgery, and then half the people get immune therapy after surgery and half the people get chemo. And so this was actually just presented June 28th. So this is brand new data from Dr. Lizzie Smith in Cambridge, Oxford now, I guess, but this is a trial called Vestige. So there's 180 patients here. You can see that about 60% are stomach and about 30% are GE junction. Most of these patients after surgery still had positive lymph nodes or a positive margin. That's what R1 means. And you can see these curves, and it looks like there's a separation between the two, and that's great. That's exactly what we want to see. The problem is that the blue curve is on top, so that's the one that's doing better. And the blue curve is standard chemo after surgery, and the red line is immunotherapy. So in this case, immunotherapy was actually worse. If you look at the actual numbers here, what you'll see is that the median recurrence-free survival, so how long you're alive after surgery before your cancer comes back, was 1 year in the immunotherapy group and 2 years in the standard group. So this is definitely not what we wanted to see. We wanted to see the flip-flop of these curves, but unfortunately, this is what we saw. So this tells us that we still don't know exactly how to put immunotherapy in, but we know that this is not the way to do it. So if you go to your oncologist and you had a bad response to chemo at surgery, and then you say, I want to do immunotherapy only after surgery, that looks like the wrong answer. What about bringing the immune therapy part into the beginning? So now you're saying, okay, let's combine the chemo with the immunotherapy up front, then do surgery, then do chemo plus immunotherapy on the back end. So everyone gets immunotherapy before and after surgery with chemo. And this is a trial called Dante, and this is also relatively recent data. And that's exactly what they did. You see half the people get FLOT after surgery and before, and other people get FLOT plus atezolizumab before and after surgery. And we don't have long-term outcomes here, but what we can say is that when they added immunotherapy on top of the chemo before surgery, they improved the response rate measured by the surgical specimen at surgery. So we call that the pathologic response rate. The complete pathologic response rate, you can see was primarily driven by tumors that were PD-L1 positive. So it's another argument that maybe in addition to MSI high testing for stage 2 and 3 patients, we also need to think about PD-L1 testing, because that's going to tell us who might benefit the most from immune therapy before and after surgery. This was a very similar strategy that was just presented last month at the annual ASCO meeting. So this was a phase 2 trial, and this was an Asian trial basically asking a very similar question. If we give chemo before and after surgery along with immunotherapy, does it make it better? And so very, very similar idea. Half the people got standard chemo before and after surgery. The other half of the people got chemo plus immune therapy before and after surgery. And the primary endpoint here was, again, pathologic response rate. And the reason people pick pathologic response rate is because we get the results right away. Once you have surgery, we know that result. So we can get the findings of the trial pretty quick. This is what they saw. So again, the left side is just who went on to the trial. That's more detail than you probably need. The right side is that if you look at chemotherapy, so chemotherapy alone, there's only about a 7% chance that you have a complete regression of the tumor when you have surgery. You have a complete pathologic response. When they add immunotherapy before surgery, that went up to 22%. And that is very encouraging, but what we're trying to do is cure patients. You know, we want to know about the path response rate, but we want to know is, are there more people alive without disease beyond 5 years or 3 years where we can feel like, okay, we're actually curing more people with immunotherapy? We don't actually have that data yet. These are the two studies I'm going to show you that are probably going to, well, may change that, statement I just said. And so this is called the Matterhorn trial, and it's just a bigger version of what I just showed you. So this is standard FLOT, very clean study, nicely designed. Half the people get FLOT, standard of care, so FLOT before and FLOT after surgery, and the other half of the people get FLOT plus immune therapy before and after surgery. And then they want to know, are we keeping people alive longer without cancer recurrences? The problem is we don't know the answer yet. So just 6 weeks ago, AstraZeneca had a press release that said their first checkbox was hit. So the adding the immunotherapy improved the pathologic response rate. And that is exactly what we would have expected based on the data I just showed you. But again, what we really want to know to change practice is, are we curing more patients or are we preventing recurrences in more patients? And we just don't know the answer yet. This is the other big study that might help give us an answer. This is called Keynote 585, and this is from Merck, and they also asking the same question, which is, if we add Pembro before and after surgery on top of chemo, does it improve outcomes? And you can see that the endpoints here are pathologic complete response, so that's a quick one. And then the more important ones are event-free survival and overall survival. Merck had a press release just, a month ago, that, again, they improved the pathologic complete response rate so that more patients had no tumor at the time of surgery. The problem is it didn't improve event-free survival, which is like how long you're alive without recurrence. And therefore, they didn't even test for overall survival. So this puts a little bit of damper on the idea that immunotherapy before and after surgery is a fix for everybody. We still need a lot more data, and probably we will be able to tease out some groups like the PD-L1 positive patients who actually do benefit from this strategy. But as of right now, ASCO 2023 has not yet changed anything for the patient who walks in the door tomorrow. So if someone comes in the door to my clinic tomorrow, obviously trial is the first answer if we have one, but outside of a trial, FLOT is still the standard answer for people who have gastric cancer that is locally advanced. You can also still consider surgery with chemo on the back end, although that's a very uncommon approach in the US and not typically what we do. But it tells us that, probably there's not going to be a one-size-fits-all approach. And really what we need to be doing is more like identifying groups like the MSI high who really do very, very well. And they do so well that we maybe even get away without chemo completely. And rather than trying to throw immune checkpoint inhibitor on everybody, we need to be a little more thoughtful and try to really pick the people that it's going to work the best for. Okay, so that's the first half of the talk, which is stage 2 and 3 patients. Unfortunately, as many of you know, almost half, if not more than half of our patients in the United States present with stage 4 disease. So early stomach cancer doesn't have a lot of symptoms. The US doesn't have a screening program. And so by the time patients feel symptoms, unfortunately, it's usually been there quite a while and has had time to spread. Most common sites of spread are typically other lymph nodes, the liver, lungs, and bone to less so. So we have a bunch of tools, and we're always trying to add more, but chemotherapy is one, immune therapy is one, biologic or targeted therapy, and then local therapies like radiation and surgery where you're dealing with specific areas, and then of course clinical trials. That's obviously what we try to do the most of to improve these numbers. I just wanted to back up for a second to make sure that we're all on the same page as we go further. So first of all, almost everybody needs chemotherapy. Unfortunately, we don't yet have ways to get away from chemo for most patients. What you do first, your first combination of chemotherapy-based approaches in stage 4 is called first line. We often abbreviate that 1L. Second line and third line, I think you kind of get it. It's like you repeat what you do next. And so I just put the typical ones on the bottom. FOLFOX is the most common first line. Taxol and ramucirumab is the most common second line. And then third line is anything you haven't done yet before. Obviously, this is very broad structure and every person is a little individual. And we try to tailor this as best we can, but this is just a framework. Okay, so I'm probably dating myself. I'm 42, and I do remember we were allowed to watch cartoons for like a half hour on Sunday growing up, and G.I. Joe or whatever it was called, the USA Cartoon Express, G.I. Joe and something else. But knowing is half the battle, and really that's the job of us in stage 4 patients, is to learn as much about the tumor as possible. Everybody's tumor is a little different, and use that information to pick and tailor the treatment as best we can. So this is basically biomarkers. And biomarkers are things that tell us about the tumor or the patient. So predictive biomarkers are things that tell us, are you more or less likely to respond to a given therapy? So HER2 positive patients are much more likely to respond to HER2 therapy than a HER2 negative patient. We don't even use them in HER2 negative patients. That's a predictive biomarker. Prognostic biomarkers just tell us about the cancer, like, is this a really bad cancer? Some cancers are more aggressive than others. Every patient's a little different. And so there are sometimes features of tumors where we know that the survival is worse if you have that biomarker than if you don't. Doesn't mean you're not going to respond and you couldn't do really well. It's just on average, for example, if you take everybody with a KRAS amplified tumor and you compare them to everyone without a KRAS amplified tumor, on average, the KRAS amplified tumor has a shorter survival. So that's a prognostic biomarker. This is the bare minimum. I don't know why I've always liked the analogy of like kicking the tires on a car. You know, like you wouldn't buy a car without having some sort of inspection so you know that it works before you invest. And I kind of think of cancer a little bit the same way. You know, we don't really want to start treatment until we've kind of kicked the tires of the tumor and understand what are the features of that tumor, and we've done an inspection. And so the bare minimum to pass inspection is you need to have a HER2 testing done, you need to have PD-L1 testing done, and you need to have MMR or MSI testing done. Everything else is a bonus. Our personal opinion is that, you know, we try to offer everything to everybody, and so we do the sequencing and these more expanded testing, but the basics are here, and that's what really needs to be done for every single patient. These are some other biomarkers that I'm going to walk through a little bit in the data. So on the left side here is a list that includes the MSI high, the PD-L1, and the HER2 that I mentioned, but it also adds a few others that are interesting that we're getting data for. So Claudin 18.2 is hot. We're going to spend a little time on that one. EBV, FGFR2b, and then, as I mentioned, the sequencing. On the right is just how this testing is done. Some is done by pieces of the tumor, so you need tissue. Some of it is done by blood or DNA sequencing from tissue, and you don't need biopsy for some of those. PD-L1 is really just so basically when we see PD-L1 on a tumor, that's a tumor telling us that it has used a mechanism to hide from the immune system or suppress the immune system that we actually know about. So in general, when you get, let's say you get an infection, you need a way to rev up your immune system to fight the infection, but when you've cleared out the virus or bacteria, you also need a way to turn back down your immune system. And so normally the body uses PD-L1 for that. Once you have an infection, at the same time you're fighting the infection, you start to upregulate PD-L1, and what PD-L1 does is turn down your immune system. So it's like a tunable thing. And so cancers are smart, and they said, okay, if PD-L1 turns down the immune system, I don't want to be eliminated by the immune system either, so I'm going to put PD-L1 on myself, and that's going to help me suppress the immune system from eliminating me. And that's exactly what happens sometimes. And that's what, when we say we want to know the PD-L1 status, that's why, because it tells us that the tumor is probably using that mechanism in some way, and that's something we can go after. So this is from a few months ago, and I'm not going to spend a lot of time here because this is just more data adding to the idea that chemo plus immunotherapy for the first line, so newly diagnosed metastatic patients, is an approach for some patients. So here they took standard chemotherapy, and half the people got tistolizumab, which is another immunotherapy like pembrolizumab or nivolumab, and half the people got that, and half the people got a placebo. And then the primary endpoint here is overall survival in the PD-L1 positive patients. So everything you're about to see is for people who have a score greater than or equal to 5 on their PD-L1. These are the people that went on. I'm not going to dwell here. And so here you see something that's a little closer to what you want to see. If you look at this curve, again, you're looking at time on the bottom going horizontally and a percent of people alive going vertically. And you see that over time, the people that got immune therapy, the green line, there's more people alive at every given time point. So that's extending the survival. And you can see if you compare the numbers here, 12.6 months survival with chemo alone versus 17.2 months survival with chemo plus the immune therapy. Again, these are all people who have greater than 5%. So in the people that are using PD-L1 as a mechanism in their tumor, if you give a PD-L1 or PD-1 inhibitor, it helps those people. This doesn't tell you if it helps the people who have scores less than 5, because their tumors might be using other mechanisms. So for high PD-L1 tumors, this is data that supports adding immunotherapy to chemo. This is another study that was just presented about 2 months ago at ASCO. So again, very similar question here. This is pembrolizumab, just a different PD-1 inhibitor. And so this is, again, first-line patients, so newly diagnosed stage 4 mostly. And these are people who got chemotherapy plus placebo or chemotherapy plus pembrolizumab. And what I'm going to show you here is really to highlight the PD-L1 importance. And so if you look at the far left, this is lumping everybody together. So these are PD-L1 positive, negative, low, high, etc. And you see that if you lump everyone together, there's not a huge difference in the median survival, 11.5 versus 12.9. It's about a month and a half, 6 weeks difference in survival. If you start to pick the tumors that have the higher or the highest level of PD-L1, you see that, one, the survival is getting better and the difference is getting bigger. And so if you compare the left all the way to the right, you see, one, the survival is 12.9 versus 15.7 months. So these are the people who are most benefiting from the immunotherapy. And that's why the curves separate the most. The hazard ratio there is 0.65 as opposed to 0.78 on the far left. And so this helps us select the patients who are most likely to benefit. Again, I'm not going to go into this. And again, the same thing holds for progression-free survival and response. And so if you look, again, let's compare the far left to the far right. If you look at the amount of time before the treatment stops working, you see it's much longer on the far right than on the far left. And also, if you look at the response rate, so this is the percent of patients who have greater than a 30% decrease in their cancer. So one of the first things that newly diagnosed patients come in, they want to know, like, how likely am I going to respond to this therapy? So if you look at the far left and you lump everyone together, it's about 50-50 if you get immunotherapy. 50% chance you'll respond, 50% chance you won't. If you have a very high PD-L1 score, that 50 goes up to 60. And obviously, we'd like it to be much, much higher than that, but we're getting better at selecting the people who are most likely to benefit. It doesn't mean that if your score is 8, that you're not going to benefit at all. It's just when we see the trend, the higher is the greater the chance of benefit. And this is, to me, rationale or support for why you should test. Because when we have discussion with patients, we want to be able to tell them, is it 60%? Is it 50%? Is the survival 18 months or is it 12 months? And we use information from the biomarkers to help us guide that because it's important. It's information you want to know. It's information that we want to know. All right, so what does this mean for you? So Rationale 305 and Keynote 859, the two trials I showed you, those are positive phase 3 trials. So it's just more evidence that immunotherapy plus chemo for newly diagnosed metastatic patients can be helpful for some people. We need to still test. As I showed you, the amount of benefit you might get depends on your PD-L1 score. This is clear a relationship, and you really need to talk to your doctors about, how you're going to incorporate the testing and what your score number is. All right, I'm going to spend probably the most amount of time of any of the new targets talking about Claudin, and the reason for that is that we expect sometime in the coming months that this is going to be a new drug that's going to be regularly available for patients. So what is Claudin? Claudin is a protein that basically holds cells together. It's like you put a screw between two boards to hold the boards together, and Claudin 18.2 is the screw. It basically holds the two things together. And it's only in normal stomach. It's not expressed in like your skin or other areas of the body. When you get a stomach cancer, the Claudin gets reorganized. It's like if a hurricane tore through a house, boards get ripped apart, screws that were now hidden in between boards are now sticking out. And so obviously we don't want patients to have cancer, but because that happens, we can take advantage of it. Now the protein, the screw is sticking out and we can get at it. And so Claudin is expressed now on the surface where our treatments can get to it. This was the study called Spotlight, and there's another trial called Glow, and these are two big phase 3 trials. The conclusion is the same. Both of them show that the addition of adding Claudin therapy to patients who have the Claudin protein improves survival. So here they took patients, they tested them first to see if they had these exposed screws, the Claudin testing on the surface. And so you were only allowed to go on the trial if more than 75% of your tumor cells had moderate to high expression of the Claudin protein. So immediately we're selecting people who have a biomarker, in this case Claudin 18.2, to go on a therapy. And the reason we're selecting people is because if the target's not there, the drug's probably not going to work. So this is not a one size fits all for everybody. This is for Claudin positive patients. And then they randomized them to placebo plus Folfox or Folfox plus zolbetuximab, which is an antibody that binds Claudin 18.2. And they wanted to know, does this improve progression-free survival? So the amount of time you're on the drug and alive without progression. and overall survival, the total life expectancy. These are the people that went on the study. Again, I'm not going to spend time on this. Here's the primary endpoint. So progression-free survival. So this is the time from when you start the treatment to basically the time when the treatment stopped working for you. So with chemotherapy, it was 8.6 months, and it was about 10.6 months. So, you know, pushing close to a year that people are getting out of Claudin plus chemotherapy. This is actually better than what was shown in Claudin plus immunotherapy. I mean, in chemo plus immunotherapy, but you can't really compare between two trials, so that's not really a fair statement, but just using the numbers alone, it is longer. Obviously, you all care and we care the most about overall survival, and overall survival here was also extended. So people who got the Claudin antibody, zolbetuximab, their survival was improved by about 3 months. 3 months is still not good enough, but 3 months in our world is considered meaningful, and obviously 3 months is 3 months. A lot can happen, and so this went from 15 to 18 months. 18 months is actually the longest survival that we've seen in phase 3 trials, really. So this is, again, encouraging. This drug is not without side effects. So, you know, anytime we're giving a therapy, it's a balance of, you know, we want to keep you alive as long as possible, but we also want that time to be good time so you can do all your things you want to do and live your life and not feel unwell. So the extension of survival does come at a little bit of a price with this drug, but of course this doesn't affect everybody, but you can see that a large portion of patients here, and so it's 60% with chemotherapy and it's 80% with adding the zolbetuximab, will get some form of nausea. This could be very mild where it doesn't bother you, but it could also be quite life interfering where you're nauseated and you're throwing up. That's about 16% of people. And so this just tells us that, yeah, it's a good drug. It adds life expectancy, but there are some patients who will have nausea and vomiting. So this is obviously, you have to decide if that's something that you're willing to do or stick with if you have it, or manage through it. That's a lot of our job is trying to manage the side effects of the things we do. But I just, for the completeness, you know, it's a good drug, but there are some side effects. Importantly, the side effects tend to happen early. So on the bottom across the horizontal line is days. And so you see that the nausea is very early. About the percent of patients who have nausea early on is high, but as you go and stay on the therapy, you can see the rates of nausea become significantly lower. And so if we kind of support people through the beginning, we may be able to get to a place where the nausea is quite tolerable. There are, of course, a lot of other Claudin strategies. There's CAR T cells against Claudin, there's bispecifics, there's antibody drug conjugates. None of these drugs are approved yet. They're all in clinical trials at multiple institutions around the country. We don't know which of these approaches will be best. They all have shown some activity. And so if you have access to this, in my opinion, these are all very reasonable options. Ultimately, the Claudin drug that I just showed, zolbetuximab, is likely to be approved by the FDA probably in the next few months. All right, what about other immunotherapy targets? So TIGIT is one that's gotten a lot of press because there's some good data in lung cancer and some other tumors, but basically same idea as PD-L1. TIGIT is another surface molecule that can be used to suppress the activity of T and NK cells. This is people who were rather heavily pre-treated, so had received multiple different lines of chemotherapy. You see the 3L and the 4L and the 2L, but about 25% of people responded to immunotherapy plus TIGIT, so no chemo here. So this was encouraging in a pretty mixed group of patients. And it was the support for this phase 3 trial that's now open. It's open at our center, it's open at a lot of centers around the country. And so this basically takes patients and we're saying, okay, so chemotherapy plus immune therapy is a standard for many patients, but it's still not good enough. What if we add a second immune therapy on top of chemo plus immune therapy? So here, half the people get immunotherapy plus nivolumab, which is a standard, and the other half of the people get chemotherapy plus a drug like nivolumab, in this case, zimberelimab, and then they also get a drug against TIGIT. So we're basically asking, does adding TIGIT boost the effect of immunotherapy beyond what you get for one immunotherapy drug? This is ongoing, so we don't have any data to present yet, but certainly an option if it's available to you at a center nearby. I'm going to end in the last 10 minutes or so by talking about the microenvironment. So this is really a hot area of research and drug development, which is, we used to kind of think of tumors just as themselves, and we go after the tumor cells, and that was the focus. It was on the tumor, on the tumor, on the tumor. Tumors don't live in a vacuum. They live surrounded by other cells in little neighborhoods where there's a tumor cell here, immune cell here, different kind of immune cell here, one over here. And it turns out that the little neighborhoods they live in actually really matters, because if you live around a bunch of bad immune cells, that's not a situation where immunotherapy is going to help you. Immunotherapy alone is not enough in that scenario. So we're really learning, and this is a lot of what some of our own research is focused in, is trying to tease apart these communities and these neighborhoods and understand if we can target them to make them more favorable in terms of the immune system, which means more likely to respond to an immune therapy. One target that I've been interested in a little while is something called DKK1. And so basically, you can just focus on the far right here, and this is what the difference between two neighborhoods kind of looks like at the cell level. So you've got tumor cells in gray, and then you've got very few good immune cells, which are the orange circles, the T cells, and you've got very few green cells, those are the NK cells. Generally, you want to have a lot of those because those are the soldiers. Those are the ones that actually get amped up and kill the tumor. So in this neighborhood, and that's why it says immune evasion over there, in this neighborhood where there's a lot of DKK1 around, there's not a lot of whatever, let's call them cops, let's call them soldiers, whatever you want to say, there's not a lot of good immune cells. If you take away the DKK1, it actually brings in a bunch of good immune cells. And so that's what the red and the purple are in the bottom right. And so obviously, what if we had a drug that could do that? That's exactly what this drug called DKN-01 does. And so this is a trial that I've been involved in and presented at ASCO just a month and a half ago, basically asking that same question. If we add DKN-01 on top of chemo plus immune therapy, can we increase the number of patients who benefit? And these are the patients that went on the trial. And as you can see, about 50% of people had high DKK1. This is encouraging, but the numbers are very small. So there's only 22 patients here. So it's not like we have 500 patients where we can feel really confident that this is real, but this is where stuff starts. You got to have a signal before you want to invest all the time in a big phase 3 trial or something like that. So here, if you look at the DKK1 high patients and you take the DKK1 away from them, the response rate there was 90%. That's very, very high and very, very encouraging. If you look at the everyone lumped together, the response rate's around 73%, which is still good. We saw with chemotherapy plus immune therapy, it can be as low as 50% response rate. So if we could take that 50 and go to 73, that would be great. Again, this is all small numbers, so take it with a grain of salt. The drug is relatively well tolerated, a little bit of GI upset, but again, if we're adding a therapy, we want to make sure that it's tolerable to patients, and this looks encouraging. Again, small numbers early on. And that was sort of the target I wanted to wrap up with. Again, that trial is also open around the country. Our center, MD Anderson, California, multiple places around the country. So this is me. Happy to take questions in the last 10 minutes, and look forward to seeing many of you in person at the booth at the next meeting.
Awesome. Thank you so much. Did you want to go over these take-home points or?
No, because that was a mistake, and I left that slide in from the last time I gave a talk on a slightly different topic.
Okay, just making sure.
Yeah, I mean, those are good questions, but you can certainly post these slides. These
Okay.
are things that I just put in there that, things that you should ask your team. And basically, there's actually some really good guides for patients. If you look at the NCCN guidelines for patients, it will give you a whole list of questions you should ask your doctor. And Debbie's Dream Foundation also has a lot of very similar resources on the website. And this is a great way to make sure you're getting well cared for. Like I said, we need to do MSI testing, and so probably the person who's the most invested in doing well is the person with the cancer. Obviously, your doctor wants you to do well, but you're the one with the cancer, and so anything you can do to empower yourself and educate yourself and ask the questions is probably going to result in you getting better care. So I put these here as just an example of a few.
Perfect. Well, thank you so much, Dr. Klempner. Your presentation was amazing as usual. We did have a few questions that came in that I'd like to have you answer. So first question that we have came in from Lalitha, and she says, when should we consider second line? Is it after first line is complete or if first line doesn't work?
Yeah, so great question, and it's individual. It's a judgment. It's based on how well things are working, but also how well you're tolerating them. So, if someone is spending all their time in the hospital feeling horrible, even if they're responding, that's not a good balance. The easiest answer is that if the therapy has stopped working, meaning the tumor is growing or spread to new places, that's the most straightforward time to change from first line to second line. The other ones become a little bit harder to have hard guidelines on because they're very individual. It could be that you had a perfect response and there's no cancer at all, so you're going to take a total break from therapy. And then if the tumor acts up, you might consider switching to second line or restarting first line if you've been off therapy for a while. So it can get very individualized in many situations, but the easiest answer is that if you have a scan that's showing growth or you're having worsening symptoms or something, that's the easiest time to transition from first line to second line.
Okay, thank you so much for that. We have Jenny who asks, is zolbetuximab only approved for first line of treatment in combination with FOLFOX only?
Yes, I think I did it. That makes me feel good because it makes me feel like I got the lines of therapy point across. So yeah, basically the approval is linked to how the trial was done and who they studied it in. If your trial was done in the second line, then the only people we know and have data for is going to be the second line population. And so that's where the drug is going to get approved. The zolbetuximab, the Claudin drug, right now, the only phase 3 trials have been done in the first line, and they were done in combination with FOLFOX. And so the FDA label, when it comes out, assuming it comes out, which we all believe that it will, is almost certainly going to be restricted to people who have Claudin positive tumors in the first line setting in combination with 5-FU and platinum. So you could get, CAPOX or FOLFOX. But in general, it's going to be a first line therapy. There's a lot of new Claudin drugs that are being tested in the second line because that's also a very good question. We just don't have data.
Okay, thank you. Lalitha has a second question. She says, we heard about S1 and we want to know, how does it help?
Yeah, so S1 is a pill and it's very similar to 5-FU. So capecitabine is a pill, also version of 5-FU, and the other 5-FU is the drug you get in a pump with FOLFOX. They all generally work the same way in terms of how they kill tumor cells. S1 has some other components that might make it a little less harsh on the GI tract. It's actually not available in the US, it's only available in Asia where it's approved. They did a study in the US a long time ago comparing S1 against capecitabine, sort of our traditional 5-FU, and at least in that trial, there was not a difference between S1 and capecitabine, so that's part of the reason S1 is not approved in the US. Good drug, definitely active, very common in Asia, but not available in the US.
Thank you. Another question was, how does the patient go about making sure we get tested for MSI?
Yeah, so I think, you know, basically asking. I mean, it should happen without you needing to ask. Like all the big cancer centers, like when we see a new patient, we basically either are emailing our pathologist if that result is not already being done and say, what's the deal? Or we're getting a new biopsy to test for ourselves if we need to, because the information is that important. But I think, you know, like Debbie's Dream and a lot of the advocacy groups on the website have a sort of informational space about biomarkers. And so, like, personally, I would never be offended if a patient walked into my clinic and is like, here's the pamphlet, what are my biomarkers? Because that's someone who's educated themselves, and that's great. So sometimes it's just, you need to ask. You know, there are some oncologists who treat 50 different cancers because they have to, and they're in rural Maine, and they see one stomach cancer a year, and you know, they can't possibly be up to speed on every single cancer. So they might not know that MSI is really important to test in gastric cancer. Just like I don't know what to do with breast cancer. I don't take care of any breast cancer. So sometimes it's the patients that come in and say, you know, I need to have my tumor tested for MSI high, and you know, that just ask.
Okay, thank you. Another question, how does the patient advocate make sure that they get the right treatment for their loved one?
Yeah, I think again, information. There are some broad principles like 5FU and platinum are the backbone for first line. I personally think, and I know this is easy for me to say, but just not the reality for everybody, is that we know that big cancer centers, which are unfortunately usually in big cities, they have the most resources. So they have dietitians, they have social work, they have palliative care, they have all these additional resources that can translate to better experience with treatment and ultimately better survival. And so it's my own opinion that, you know, everyone with stomach and esophagus cancer, because it's a relatively rare cancer in the US, should try to get seen at least for an opinion, whether it's virtual or in person at a big cancer center, because that's where you're going to get the best care, not necessarily the best care, but at least care that's consistent with the guidelines. And then go get the treatment close to home. You know, we see a lot of patients as a second opinion from all around the Northeast, and you know, we don't want people to drive 4 hours to get the same chemo that they could get 10 minutes from their house, but we just want to make sure they're getting the right chemotherapy or a combination with immunotherapy or etc. So I think this is the reason to try to get seen once at a big center. It's, again, I totally understand that it's a very easy thing for me to say, but it's just not possible for many patients, and that's sad. We need to do better about that. But that's sort of my answer.
Thank you so much, Dr. Klempner. It looks like we got one more question before we conclude. Can you speak to the chemo shortage in the US? Has this been affecting the stomach cancer community?
Oh man, I think it annoys everybody that this even happened in the first place. It's just, you know, money really. You know, old drugs are dirt cheap and companies don't make a lot of money, so there's not as much, I guess, interest in making these drugs. But yeah, it affects a lot of people. I mean, I think, again, big centers tend to have the biggest stockpiles and things. So, you know, thankfully for our own patients, it hasn't been an issue. We're getting told from our leadership, you know, that, you know, we need to pay attention to this and stuff. So, but for smaller practices that don't order as much, or they don't have the same kind of contracts with providers and insurances, like it's more affecting. So I think this will get solved. I mean, everybody recognizes that it's been kicked up to the highest possible levels, including, you know, the Congress and etc. And so I do expect this is a solvable problem, because it's not like these drugs are hard to make. It's kind of a matter of like turning back on the faucet. So I don't think it's going to be a long-term problem, but it definitely is affects some patients. There's no doubt.
Thank you so much, Dr. Klempner. Unfortunately, it looks like we are out of time for more questions today. But Dr. Klempner, we would like to thank you again for joining us and taking time out of your busy schedule to educate our community. We always appreciate these things, and it's how we keep our community educated. So
yeah, I look forward to the next one, and have a good weekend.
You too. Thank you. So please visit the DDF website for some of our upcoming events and programs as listed here. And this concludes today's presentation. We thank today's speaker, Dr. Klempner, for taking time out of his schedule. Thank you also to our generous sponsors for making today's program possible. And to review any of our recorded webinars, please visit our lecture library on the DDF website at www.debbiestream.org. And that is all for today. Thank you so much.
I can drop off now, right?
Yeah,
Awesome. Thanks a lot.
thank you.